Honestly say that our next speaker requires no introduction. He's had two already today. The organizing committee has certainly made Andrew Connolly earn his lunch by assigning him 3 separate talks. So, Andrew, the floor is yours.
Thanks very much. Following on from John Quinn's presentation, surgeon is sometimes wrong but never in doubt. So I have approached this by don't really know what feedback will be like in the future because we don't really know what the future will be like. So I've tried to do a bit of crystal ball gazing, and this is where our council is looking because it's quite clear that feedback to be relevant, it has to be relevant, and therefore it needs to be probably stratified to who needs it most, etc., etc. We know we've got an ageing workforce, but we don't know truly what the effects on competency may be, if any, depending on the specific work environment that older doctor is in. Working hours for safe practice and part-time work. What is the impact on training? I have strong views about that and experience. So that may mean we need to alter our way of approaching feedback for the trainees or the newer consultants. Urban migration, both of the public we serve and of the workforce, is a serious problem, and certainly in Australia and New Zealand. Graduate volumes are changing. We think that's an opportunity for us to change the way we can approach education and service delivery for the very new graduates in PGY 1 and 2. And that means that we should wrap better feedback mechanisms around that so that we can monitor their performance much earlier. And it goes to the concept of it's better to fix a problem than toss one out and try and train someone new. There is greater need for accountability and transparency from the public we serve and the politicians who pay for us. And costs are clearly going up, and that is definitely going to, in our country, influence the site that care is delivered in, and technology to deliver that care is rapidly changing, and we need to keep up with that, and that may well change the information or the way we assess someone's performance and feed that back, particularly if there's no longer, say, face-to-face consultations, and that may be a major component of that doctor's work. And alternative workforces will no doubt come in some way, shape or form. I personally think, and it came from a comment earlier in the day, that the alternative workforce I most need in my hospital is someone to do the very trivial tasks that I currently have the registered medical officers doing, rather than cutting away at the top 20% that Sir Peter spoke about that requires a doctor. So for strategic planning, we're introducing the New Zealand curriculum framework, similar in its design to the Australian framework. We must ensure that our regulatory practices allow for positive change, and that includes the information that the regulator thinks they need. I'd strongly support the comments that Joe made about the need for to define the role of the colleges and the regulators in this. In New Zealand, we certainly want to continue to review the outcomes of our regular practice review, and assuming that the experience to date is borne out by more data, we see that working with the stakeholders, which is particularly the colleges, on a continued introduction of regular practice review and defining what that means is very important. We've already aligned our accreditation standards with the AMC, and so that has reduced or eliminated the need for the New Zealand-based sections of binational colleges to reinvent the wheel. And we've introduced a New Zealand version for the New Zealand-only colleges, of which there's very few, but general practice is the major example. And as each of the binational colleges comes up for accreditation, the specific New Zealand requirements, which are not many, but they come into effect as each college undergoes its accreditation process. And that is a wonderful opportunity for the regulators on both sides of the Tasman and the colleges to work together on issues such as professional development, remediation of the underperformer, etc. We've started work with the colleges through the Council of Medical Colleges in New Zealand, the employers, the ministry, and we need to involve the unions on processes not only to remediate performance when there are concerns or competency issues have been identified, but also to define the standards that we think are appropriate in our environment. And we're also doing work on risk identification, which will hopefully mean we can target our data and our feedback to those who are identified as being more at risk. The workforce is changing. If the American-style PA role came into New Zealand, then we would see a significant regulatory role for the Medical Council, and that would, the easiest way to describe that is that because doctors supervise the PAs. So the role of the supervisor would be crucial, and that again will change potentially how we need to assess that doctor's practice. The impact of technology, including electronic consultations, as I said, we need to make sure our policies keep up with that. At the moment, we define a consultation as a face-to-face event, and we don't necessarily think face-to-face is Skype to Skype. So that's a really important area that we need to work on. And I doubt that we would be confident of our ability at the moment as a regulator to ask for someone's performance to be assessed if their practice is electronic. That would be a challenge for us, I think, at the moment. The way hospitals in particular are rostering their resident medical officers is changing, with more integrated programs for hospital at night is the term we use. That raises issues about accreditation of runs, feedback on individual performance of the RMOs, the role of, say, the medical registrar or the intensive care registrar as a supervisor. So I think we have to shift our thinking a little bit about the supervisor as not just a consultant. How we assess the comparability of our international medical graduate specialists who are applying. Very difficult question we're grappling with is, does experience overseas begin to mitigate for gaps in the training when you compare it with the Australasian curriculum? We certainly support the generalist philosophies of the college, but we have to recognise there is a key role for very narrow scopes of practice, and again the ability to assess that doctor or to allow their professional development to come through in a very appropriate mechanism for them is crucial for us. And we just have to agree on the data and the definitions, as was said. Curriculum framework links the university to PGY 1 and 2 right through to vocational training, core set of values, nothing terribly new here except mandatory community experience. We can't go to this straight away, but as our number of graduates increases, we are told at the moment by the data gurus that the increase in graduates will exceed the increase in service demand. That should mean we can get to the situation where we rotate our PGY 1s and 2s for 1 3-month run out of those 8 runs over those 2 years into the community. Not exclusively general practice, it may be community mental health, but to get exposure to life outside the hospital wards, emergency departments or outpatient clinics, and really to get that understanding of what can be delivered outside of those 4 walls, because that's where our health system is clearly going from an economic point of view, as well as probably from, quite rightly, from quality points of view. It involves a professional development plan and an e-portfolio, which we believe as a council should be easily accessible to the colleges for issues such as trying to pick the trainee who clearly has demonstrated a commitment to your particular specialty, rather than just writing a nice paragraph about their commitment to your specialty. That would be web-based and also obviously have their portfolio of learning on it. Work experience, wide range of clinical scenarios, acute, chronic, elective, emergency, the whole works. One thing for the future, we've recently been asked by both the College of General Practice and one of the senior academics at the University of Auckland is, can PGY1 be done predominantly or totally in the community? We don't know the answer to that, but if we do, that's going to change how those runs are assessed, what scope of practice that doctor may have, what sort of how feedback's delivered. And graduates would be pushed back to the hospital for specific experience. We're very aware, probably more in New Zealand than in Australia, that we're in danger of becoming a very insular workforce. We're small in number, and it is in our country getting increasingly distant to have a grandparent born in the UK. We had a grandparent entry scheme to the UK. We now pretty well find that most of our trainees are shut out of European training posts or post-fellowship work, and we think we need to work with the regulators around that, otherwise we're going to be in the pickle. CPD, we firmly believe the colleges remain absolutely central to these initiatives, and both fellows and the programs need to be continually developed. It needs to be evidence-based. We do believe in the expansion of the regular practice review. We certainly support the annual performance appraisals, targeted learning, skill maintenance, planning over the next 12 months, and CPD shouldn't really be about having a nice holiday and generating air miles. We've heard about departmental credentialing earlier, and we'd certainly, or departmental review, excellent concept that will again feed back information that will help doctors improve. Accreditation standards, we as a council do believe that the colleges are the right people to collect the information, but we do believe the colleges have a responsibility to share non-compliance to us. The responsibility lies to the public, but obviously the notification would come to us. We appreciate that's an area that needs more thought and work, and there may be some legal hurdles, etc. But similarly, notification of the poor performer, if it seems to be outside of a simple fix, we would like to have the the council at least aware of the problems. Early intervention is the key and may well stop the regulator having to get involved at all. And certainly we are slack historically of notifying problems until they become disasters. Many issues for the poorly performing doctor that we do need to address, and again we've heard some of this earlier in the afternoon. Where does the doctor go? We certainly have a major debate going on about what do you do with the poor performer in terms of telling the patient, and we do need to sort that out, particularly with our independent overseers, which are the Health and Disability Commission, Privacy Commissioner, etc. And how do we monitor improvement? Those are all challenges for us as regulators, and that obviously will influence the type of feedback that that doctor gets in terms of monitoring, etc. So we have, as I said before, initiating work on that, and we need to continually make it easier for the profession to ask for help. So we want doctors to ask for help. We're very good in New Zealand now. We seem to have really got to the stage where doctors will sing out for help on health issues, and the Health Committee functions extremely well. We do need to, I think, make it much easier for people to go to a colleague in their department or a colleague down the road and say, look, I'm struggling a little here, what should I be doing? Risk identification, we are allowed to profile for risk as long as there's some evidential basis. Older male doctors, solo practitioners and those in professional isolation are particularly at-risk groups, so we're told. But obviously any doctor can face issues that detract from their professional performance. So we're looking at international best practice because obviously prevention is better than cure. So developments around risk, and this will influence who we target perhaps for a more in-depth look, etc. We want to develop a matrix of fitness to practice versus demographics. So that is not just the older male doctor, it's the IMG, the new graduate, perhaps those working in the country, perhaps those working in a busy city who've only just moved there and don't have any mates. We're doing a literature review on ageing and competency, how to assess and what to do. And we want to further develop the concept of informative assessment, which is again to stress that continual development and regular review of performance is not punitive. It should be to inform the doctor being reviewed and to inform his or her colleagues of how to make this better. So multi-source feedback we've heard a lot about. We are working on who, from and what volume, and you do get different opinions obviously, particularly if you have to arrange it yourself, you want to arrange two. But the practice review issue needs to, we believe, will heavily influence informative assessment and benchmarking with similar practices so the individual doctor making sure that that person's practice is compared with a like practice rather than having a generalist compared with a subspecialist. So in summary, the future will definitely be different. We believe that we need to, as not only the regulators but also as members of the profession, be proactive. The public do demand high standards, and obviously with the privilege of self-regulation comes the responsibility to uphold those standards. We do need to be able to look the public in the eye. We believe a collaborative approach is essential, and the way we feed back will really be determined by how we're working and the technology we use. Thank you.